I'm going to talk on old and new concepts of vulnerable plaque. And indeed, Christina and Gaetano, thank you so much for inviting me to give this lecture. And it's indeed a pleasure. And it's an honor to present at such a wonderful university and such an old university. And indeed, it's having been to Padua, although not at the university, I can say that it's indeed one of the highlights for me. Italy is the highlight. To go to Italy is like going to the Mecca for me. So I think it's just wonderful. So starting with that, I would first like to say these are my disclosures, and then talking about starting with the American Heart Association classification, which came into being in the 1990s, in mid-1990s, and that was from Starry, and a group from the HA got together and came up with this classification. They classified atherosclerosis into type 1 to type 6, and what I had objected to this classification simply because they believe in the concept that there's only one way to get a thrombus, which I think over time has proven not to be true. So we came up in 2000, a classification.
Sorry, Renu, to interrupt you. Probably you should move the mouse for the slide.
Move the mouse?
Yes, I mean, the slide is still the title slide.
It is still the title slide?
Yeah.
Oh my goodness. Oh, should we, that doesn't make sense. Is it better now?
It's still the title, so probably you should move on the bottom. You see two arrow with the mouse. Yeah. There is an arrow. No, you interrupt now. Yeah.
Oh, I see what you're saying.
Yeah, that one, exactly. Okay. Perfect.
Now, can you see it?
Yeah, yeah.
The American Heart Association classification, type 1 to type 6. And I didn't like this, so we came up with a different classification. Here is our classification. We divided into non-progressive and progressive. Non-progressive being adaptive intimal thickening and intimal xanthoma, which is fatty streak. And then progressive to me starts with pathologic intimal thickening, which goes on to become fibroatheroma, then thin cap fibroatheroma that eventually leads to early and late. We've divided thin cap, meaning the vulnerable plaque, and then going on to further form the lesions of thrombosis. And these lesions of thrombosis are three. That is rupture, erosion, calcified nodule. Rupture occurring is the most dominant, 60 to 70%. Erosion is the second most frequent, which occurs with an underlying either pathologic intimal thickening or a fibroatheroma with a surface thrombus that is seen in about 30% of patients. Then is calcified nodule, which is the least frequent, seen in about 5 to 7% of cases. So just to show the gross and light microscopy, approximately 60% of thrombi in sudden coronary death. This is in people who have never had symptoms of coronary disease. These are young individuals dying at the age, our mean age was about 50 years. And that in them, what you can see is there's an underlying necrotic core, fibrous cap, which is disrupted and is infiltrated by macrophages, T cells, and these are HLA positive, and you can see the disrupted fibrous cap with surface thrombus as well. Whereas plaque erosion, typically it occurs in young women, although young men are not immune to it. This being a case showing here is a 33-year-old female with chest pain of 2 weeks duration. She was discharged from the emergency room with a diagnosis of anxiety and died suddenly 2 weeks later. And this is her LAD showing the plaque erosion on the surface, rich in smooth muscle cells. Underlying plaque is rich in smooth muscle cells. And you can see that this is organizing, suggesting that when it occurred, 2 weeks ago, it has organized since then, and you can see both platelets as well as fibrin present. And this area that is the underlying fibrous cap is not rich in inflammatory cells. Inflammatory cells are part and parcel of the thrombus. You see early infiltration of neutrophils, as well as you can see leukocytes, macrophages are present. So at that time, when we published at 2000, the ATVB, there was an editorial by Starry, and he came up with a classification saying this goes from type 1 all the way to type 8. Again, this is difficult to follow for me, and therefore I still don't like it. So we recently again updated this to come up with the same classification, but a little more in details. So pathologic intimal thickening with or without macrophages, fibroatheroma early and late, and I'll address some of these. Thin cap fibroatheroma, and then going on to, as I've shown you before, rupture, erosion, calcified nodule. And yes, there is plaque fissure also seen, which occurs in about 10% or so of cases, which Davies very nicely showed many years ago. So these are lesions of progression, which we also described, that is plaque hemorrhage, heel plaque rupture, single or multi-layered, chronic total occlusion, fibrocalcific plaque, nodular calcification, fibrous plaque, which is rich in fibrous tissue. We believe that occurs because of organization of a propagated thrombus. So those are the main lesions that you see. Now, how do plaques progress? This was a paper we wrote in Atherosclerosis, and this we showed that pathologic intimal thickening without macrophages. As you can see, there are no macrophages. There may be some T cells. There are very few vasovasorum. With pathologic intimal thickening with macrophages, you can see they're infiltrating from the intima in, and then they go and infiltrate into, likely into the lipid pool areas, as shown here. These are lipid pool areas that have proteoglycans present in them. And you may even see sometimes type 3 collagen is also present. And you will see that here there are macrophage T lymphocytes and vasovasorum increase. Early fibroatheroma is lesions in which the lipid pool is now infiltrated with macrophages, and these macrophages are actually digesting some of the proteoglycans that are present. And so that digestion of the proteoglycans leads to the formation of necrotic core. The question really in late fibroatheroma, there is true necrotic core, there is no matrix anymore. The proteoglycans are gone, collagen is gone, there is really nothing else but what we all recognize as epiltaceous debris, which is consisting of cells which have died in that region, mostly macrophages, and they're rich in cholesterol. That I will come back to. Where does this cholesterol come from? In the old days, everybody thinks everything came from macrophages, which, as you all know in culture, you can see a few cholesterol clouds, but not this many. You cannot form those things. And then, of course, there's vasovasorum. Then showing you we measured the plaques, we measured the stenosis. As you can see, the stenosis increases from PIT without macrophages all the way to late necrotic core. You can see that it is increased amount of stenosis. Necrotic core area increases, macrophage increase, apoptotic bodies increase overall. And that if you look at the engulfed apoptotic bodies, these are much less. They peak in pathologic intimal thickening with macrophages, and after that, they seem to decrease. That is, the number of apoptotic bodies that are present within each macrophage are fewer. So I want to come back to the idea of Lagoff's idea, which I think is absolutely correct. We also did a similar study and showed indeed in most vessels, you will see that Lagoff phenomenon is correct, that the lumen remains the same, but the vessel enlarges as the plaque grows. However, beyond 40% area stenosis, only then does narrowing begin to occur. And why is that important? To me, that is important because what happens, either you get a sudden plaque hemorrhage or you get plaque rupture, which are silent, and these heal suddenly, very quickly, as I showed in plaque erosion, and that actually prevents the vessel from further dilating because of collagen laying down, and you get a lot of collagen scar tissue formation, and that sudden collagen laying down is what is responsible for the narrowing that occurs very quickly beyond the 40%. So until 40% luminal narrowing, the artery enlarges while the lumen area remains the same. Whereas beyond 40%, the lumen area decreases rapidly from, I believe, two main sources, either plaque rupture or plaque erosion. It heals and then gives rise to greater luminal narrowing. This is the concept. Do thin cap fibroatheromas, vulnerable plaques enlarge to rupture? I think they do. And I think now there is evidence, clinical evidence, because from autopsy, you can't really do it because it's only seen one time. So a thin cap fibroatheroma has a large necrotic core, thin fibrous cap, and plaque hemorrhage contributes to the enlargement of necrotic core. There's discontinuous fibrous cap, underlying necrotic core, and luminal thrombosis is present. These are the differences. So why is plaque hemorrhage important? And this we published in New England Journal many years ago and showed that if you look at all areas where hemorrhage occurs, whether it's in the lung, kidney, pericardium, example being pericardium here. And if you look at the pericardium, here you've got hemorrhage, and you can see large number of cholesterol clefts. So where do these cholesterol particles come from? They come from cell membranes, especially red cell membrane is the richest in free cholesterol of all cell membranes. And this gives rise to the free cholesterol. And if you do glycophorin A staining, you can see the edges showing the positivity that it is coming from the fibers, from the cell membrane of the red cell. You also see macrophages, you also see iron, very similar to lesions of necrotic core in the case of atherosclerosis. So here what we did, we looked at PIT no core, fibroatheroma early core, fibroatheroma late core, thin cap fibroatheroma. We did glycophorin A staining, and you can see that it increases in late necrotic core and maximum in thin cap fibroatheroma. Iron increases, necrotic core is predominantly seen only in late fibroatheromas, and as well as thin cap fibroatheromas, macrophage infiltration also increases. And you can see that these vasa vasorum become leaky. So these are one of the sources how hemorrhage occurs, probably from these leaky vasa vasorum, or even discontinuity. It could be through plaque fissure, hemorrhage can also occur. So these are possibilities, suggesting all along that the free cholesterol that is seen in these necrotic cores come from the red cell membranes, and that the red cell plays a very important role. The hemorrhage plays a very important role in the enlargement of that plaque. Davies also very nicely showed that if you look at cases with beyond 50% luminal narrowing, what do you find? These are telltale images of a heel plaque rupture. You can see this is a rupture site. You can see the type 1 collagen, the previous fibrous cap that is disrupted. You can see the necrotic core. You can see the overlying cap, which is rich in type 3 collagen by serous red and polarized light. You can see this versus the type 1 collagen, which is the fibrous cap, which is type 1 collagen, which ruptured. 70% of lesions which are greater than 50% narrowed show heel plaque ruptures, whereas much less seen in those less than 50% narrowed. This is uncommon way of enlarging plaques when less than 50%, but beyond the 50%. What we did was we showed that if you look at the sites of plaque rupture, there are multiple sites of plaque rupture within that same area where rupture had occurred. If you look at one rupture site, if there are two, if you have the three, if there are four, the percent narrowing increases, suggesting that multiple ruptures can occur in the same site, that necrotic core reforms above within this area of the healed thrombus that has occurred. So we wanted to ask, what's the incident tick fire and rupture and necrotic core size? So what we did, we looked at plaques that are less than 50% narrowed, 50 to 75% narrowed, and greater than 75% narrowed in cross-sectional area. And we said, okay, what's the necrotic core size? As you can see, as the narrowing increases, so does the necrotic core size increase, both in thin cap as well as in ruptures. But what about the incidence of these thin cap fibroatheromas? The incidence is lowest in less than 50% narrowing, 50 to 75 greater, and it's the greatest in those greater than 75% narrowed. So suggesting that these are the lesions that are going to rupture, or they do rupture. That is, thin cap fibroatheromas eventually go on and rupture. They are very similar. The incidence is less, but the incidence of rupture is much greater. More than 50% show the rupture. So what is the clinical evidence that really these things do occur? So what was done in this study, combined study, what they did was they took patients who had an acute myocardial infarction and had diabetes and had adverse events. They took them, did their OCT FFR study in the non-arteries that were not the cause of plaque rupture or the cause of thrombosis or the patient's presentation. So what they did, they looked for TICFA and no TICFA regions. So they identified thin cap fibroatheroma with an FFR negative and a no TICFA with FFR negative. What they showed that the incidence of TICFA was 13% versus 3.1% in the no TICFA, suggesting that the ones that do cause symptoms over time, that is primary endpoint of either cardiac death, MI, or clinically driven target lesion revascularization or hospitalization for unstable angina, suggesting that we actually have a proof, and this was done at 18 months afterwards. So that's a fairly fast rate of repeat rupture. That is 13% of the cases of the lesions that are thin cap go on and rupture. So what I want to say here is plaque vulnerability and plaque rupture. Here's the anatomic characteristics. Here are the triggers. If you look at the anatomy of a fibroatheroma, it has a thick cap, large necrotic core, inflammation, vasculogenesis. Triggers are hemorrhage, smooth muscle cell macrophage cell death, increased matrix breakdown, reduced matrix synthesis that go and form the vulnerable plaque, that is the thin cap fibroatheroma, which consists of positive remodeling, large lipid core, thin fibrous cap, that is type 1 collagen, and infiltration macrophages and T cell with or without calcification. But what is interesting is what triggers that rupture. I think I didn't show you this, but we've recently looked at where does inflammation is maximum in an artery. We find that the inflammation maximum at the intimal medial border rather than just in the fibrous cap. Hemodynamic stresses play a role, and cap calcification can also plays a role. As you can see in micro CT, you can see the cap area showing calcification. And this can be seen in about 30 to 40% of fibrous caps that are thin that have rupture. If you look at plaque rupture, it is nothing else through systemic thrombotic state may also play, extreme physical activity, severe emotional stress all play a role. This is the disrupted fibrous cap. The cap is 23 plus minus 19 microns, infiltrated macrophage T cell, large necrotic core, positive remodeling. absent to moderate calcification. There is usually not severe calcification in these arteries that tend to rupture. So what we tried to synthesize, where do we see what, how does it progress? So we start with intimal thickening, intimal xanthoma, infrequently becomes fibrous cap atheroma, mostly comes from pathologic intimal thickening and converts to, the lipid pool converts to the necrotic core and a fibrous cap atheroma. You can get intraplaque hemorrhage, plaque fissure, thin cap fibroatheroma, it ruptures, it thromboses, and you can get much, either present with AMI, unstable angina, or sudden death, or it can be just heal silently, or it can have total occlusion, and you may again have either AMI, unstable, or sudden death. This can, because it's silently ruptured, this can then become fibrocalcific plaque over time, depending on whether they are lipid lowering at the same time on calcium. As you know, the statins also produce much more calcification in a plaque. Plaque erosion can occur from fibrous cap. We can't recognize what lesion gives rise necessarily to erosion. What are the characteristics in a fibroatheroma or pathologic intimal thickening that give rise, suddenly becomes an erosion? I think it has to do with vasospasm, but we don't have quite proof for it. But I think it is coming. It will come. One of the things we noticed in erosion cases was that the media was intact. In these cases, overall media remains intact. So thrombosis, same way presenting, or because of calcification, it can become calcified nodule. This nodule can, as you know, can get calcification, and I'll show that in a moment, and that you can get nodular calcification, which can have a thick fibrous cap as well. But calcified nodule is recognized because of its thrombus. So here is calcified nodule, which we recently published, is another cause of acute thrombosis. This is showing you the coronary tree of a patient who died suddenly with calcified nodule. You can see heavy calcification. And you can see that in this area where we actually, this is micro CT showing sheet calcium as well as nodular calcification. You can see here the nodules of calcification and overlying thrombus. And on the ends, you can see some sheet calcification as well. You can see here again thrombus, which is rich in fibrin as well as platelets. So what we did was we looked at lesions at the culprit site and looked at proximal and distal and said, there are two types of calcification that we see that forms in coronary arteries. One is collagen calcification. Calcification occurs in areas that are either with rich in collagen, that is collagen calcium, which may be type 1 or type 3, or it is necrotic core that calcifies. So that's a weaker calcium. That is a necrotic core that has calcified, because if you look at the underlying, after you do serous red staining after decalcification, you can see in collagen calcium, you can see definite collagen presence by serous red staining, whereas in necrotic core calcium, you do not see any matrix whatsoever. So that's the weakest area. If you look at proximal and distal sections, we classified it into necrotic core calcium and collagen calcium. And you can see collagen calcium is richer in proximal distal areas, whereas in the culprit site, it was rich in necrotic core area, suggesting that what happens, this is proximal section, this is distal section, this is the culprit site, that is where there is necrotic core calcium. These vessels are very tortuous. People are much older. They usually have diabetes or are in chronic renal failure. And you can see that what happens, this is the tortuous artery, stress and strain leads to the breakdown of this calcium and protrudes into the lumen. And then surface gets a thrombus formation that occurs. And on either side, you can have a sheet calcium, but in the center, it is really the necrotic core that disrupts and gives rise to. This may heal and give rise to nodular calcification. So when we look at our gender diversity in our histologic sections, we've now got 500 some cases which have thrombi. So if you look at men less than 50 years, men greater than 50 years, women less than 50, women greater than 50, and total population. Rupture is by far the most common, erosion second most common, and calcified nodule about 50%. But if you look at men less than 50 years, the amount of rupture is far higher as compared to erosion. If you look at women less than 50 years, erosion is much higher, 77% versus 30% of ruptures. If you look at women greater than 50, much higher for rupture as compared to erosion. This we published with 50 cases. This has stood the time of test, that it is still true today. That is, erosions are much more common in women less than 50 years, and ruptures in women more than 50 years of age, much more common, and the usual risk factors are at play. So in summary, what I've shown you, atherosclerosis is a complex disease. Atheroma enlarges progressively, especially in the presence of risk factors leading to arterial lumen compromise in middle age. Ruptures, plaque ruptures occur in 65 to 75, erosion 25 to 30, nodules 2 to 7%. Plaque erosions occur principally in younger individuals, especially, I didn't show you this, but especially in smokers. Calcified nodule is another substrate for thrombosis. As we age, this incidence is going to increase, especially in older. Our age group that we see in sudden death is much younger. It's in the 60s, whereas those living with atherosclerosis are much older. As we age, 70s, 80s are becoming more common, especially individuals with high coronary calcification burden, tortuous arteries, diabetes, and chronic kidney disease. Better understanding of atherosclerosis will lead to improvements in prevention and treatment. And I'd like to thank the people who helped me make this possible. Rika is a fellow with me from Japan, so is Yu Sato. Both of them helped me put this together, and have been working with me on atherosclerosis. So thank you for this opportunity to present.